My name is Brent Wiesel. I'm an orthopedic surgeon here at MedStar Georgetown University Hospital, and I'm chief of shoulder and elbow surgery. I did an extra year of training in shoulder and elbow disorders, and my practice focuses primarily on surgery about the shoulder and elbow. My interest in shoulder and elbow surgery came from my experience growing up. I was actually training for the 1996 Olympics in whitewater slalom kayaking when I dislocated my shoulder. I ended up needing 2 surgeries to fix it. And the shoulder got better, but not quite good enough to go back to racing. We used to do almost all shoulder surgery with big open incisions. That's the type of incision that I had in my arm. Now we're able to do a lot of those surgeries arthroscopically, so with a camera and some small instruments. We also are now much better at doing shoulder replacements, which is something we very commonly do in people with arthritis. The most common surgery I do is a rotator cuff repair. People starting in their 30s and 40s and beyond tend to get problems with their rotator cuff. It's sort of like the gray hair of the shoulder. And once that goes on to a full tear of the rotator cuff, they often need surgery to fix it. The results with the proper surgery and the proper rehabilitation tend to be excellent, and we often get people back to 100% normal function. I think there's a lot of advantages to coming to MedStar Georgetown. One is the very close relationship we have with our physical therapists, both with the physical therapists here at Georgetown, but also with the physical therapists throughout the NRH therapy network. So this really lets patients, if they're from the area, they can do their therapy here, but they can also do it at several of the NRH locations that are very close to where they live. We even see patients at some of those locations, the one in McLean and the one in Chevy Chase. It's also an academic medical center, and so you'll find in the Department of Orthopedics here, each one of us really specializes in just one thing. And so all I do all day is think about shoulders and elbows. Another advantage is the real emphasis on safety and nursing care here at Georgetown. Our nurses are superb. They've won numerous awards, and safety is a very common buzzword in medicine right now, but it really is a priority here at Georgetown. The great thing about being a surgeon is that in a relatively short period of time you can take people that have often a very frustrating, long-standing problem and really make them better and get them back to doing what they want to do. The rotator cuff is a series of 4 muscles that start on the shoulder blade and go out and attach to the proximal humerus. The purpose is really to keep the ball centered in the socket in the shoulder joint. And it's the most commonly injured area of the shoulder because the top rotator cuff muscle actually runs underneath the top of the shoulder blade in between there and the ball. And so as you lift your arm up, you can often pinch the rotator cuff, and that's what leads to injury and eventually to tears. The rotator cuff is 4 muscles, and then they become tendons, which is how muscles attach to the bone, and it's the actual tendon that gets injured. And the most commonly injured one of the 4 is the supraspinatus tendon. The good news about rotator cuff injuries is they don't necessarily need surgery. Certainly inflammation or partial tears of the rotator cuff, the vast majority of the time, we can make better with physical therapy, or sometimes a combination of physical therapy and a cortisone injection. If a rotator cuff does go on to become a full tear, in patients who are very active and young, we often recommend that they have it fixed. In more elderly patients, they sometimes can compensate for the tear so well that it doesn't affect them, in which case they don't have to have surgery on that either. Arthroscopic surgery uses a camera and specially designed instruments to perform the surgery, and this has a lot of advantages over traditional open surgery where you had to make an incision and go through the muscles around the shoulder in order to fix it. With the arthroscopic surgery, we really can get right to where the injured area is. We can often see it better than we could with open surgery, and then once we're done with the repair, the recovery tends to be quicker because you don't have to wait for the injured muscle to heal. So shoulder replacement is actually a very common surgery, not quite as common as hip and knee replacements, but they are done very commonly. and they tend to work great. They're designed for patients with arthritis in the shoulder, which you don't get quite as much as you do in the hip and the knee because we don't walk on our arms. But once you do get it, it can be incredibly debilitating, and shoulder replacements tend to be a great surgery both in restoring patients' function and also improving their pain. So when we replace a shoulder, we actually replace the ball side with a metal ball and a stem that goes down the arm bone to help hold it in place. And then on the socket side, we put in a plastic socket that we cement into place. And when you put these two together, it gives you a new joint surface. The reason we do it is for arthritis, which means that you've worn out the cartilage in the shoulder. So two surfaces here that used to be 1,000 times smoother than ice start to look like a gravel road. And that's what causes people pain and often popping and clicking in their shoulder. And so by resurfacing the joint, we eliminate that pain and restore the motion. It's not quite as common as hip and knee replacements. There's about 200 to 300,000 hip and knee replacements done each year in this country, but there's actually about 50,000 shoulder replacements done a year. So it's the third most commonly joint that's replaced. You don't walk on it, so it doesn't wear out quite as often as the hip and the knee, but it is replaced fairly frequently, and those patients tend to do great. They're some of my happiest patients. So a standard shoulder replacement involves replacing the ball with a metal ball and the socket with a plastic socket. And this is a great operation for people that have arthritis but have a functioning rotator cuff. But just like for a normal shoulder, for a shoulder replacement, you need to have your rotator cuff working. And we used to not have any solution for patients that had arthritis and also had big tears of their rotator cuff. About 10 years ago, we started doing an operation in this country called a reverse shoulder replacement, where we actually put the ball on the socket side and the socket on the ball side. And that allows you to compensate for not having that rotator cuff and really move your arm using just the deltoid muscle. And so that gives us a great solution for patients where we didn't have an option to be able to help them before. So this is the reverse shoulder replacement, where what we do is on the ball side of things, we actually put a plastic cup, and this holds the cup in place going down the arm bone. And then on the socket side, we put a metal ball. So this is a model, but in the real implant, this is made out of metal. And when you put the two of these together, it's much more stable than a normal shoulder, and so it lets you compensate for not having that rotator cuff. Now, while this is a great operation, it's still not quite as good as a normal shoulder replacement. So for patients that have an intact rotator cuff, we do a normal shoulder replacement. And even though this is the newest and greatest thing we have, it's not quite as good as the normal shoulder replacement. For patients that have arthritis and a rotator cuff tear, though, we didn't used to be able to help them at all. And so now with this, we've got a great option to help them as well. This really tends to relieve pain and lets them get their arm up at least high enough to be able to comb their hair and put things in a cabinet. So the shoulder is made up of two major joints. The first is the joint where the collarbone meets the top of the shoulder blade, and that's referred to as the acromioclavicular joint. The second joint is the actual ball and socket joint itself, and that's called the glenohumeral joint. And you can injure each of these. When you injure the acromioclavicular joint, that's known as a shoulder separation. And so the shoulder blade will typically go down and the collarbone will come up like that. And that is very common in football quarterbacks who land on their arm or hockey players who get checked into the boards. The other injury that we see in the shoulder is to the ball and socket joint, and that's when the ball actually comes out of the socket, and that's known as a shoulder dislocation, and that can happen both out the front or the back. So when your shoulder actually dislocates, it often requires a trip to the emergency room to have the shoulder put back into place. And then depending on how many times it's happened, we often can make you better with just some physical therapy, although if it happens multiple times, you may need surgery to help hold the shoulder in place. For a shoulder dislocation, what we need to do is fix the torn tissue that helps to hold the ball in the front of the socket. Most of the time, we can do that arthroscopically using a camera and a specialized set of instruments, and go in there and we put some suture anchors to sew that tissue back in place on the front of the socket. If the bone on the front of the socket is fractured or has been worn away, we sometimes have to go ahead and do an open surgery where we may repair that piece of bone, or we may even replace it with another piece of bone from somewhere else in the body to rebuild the socket and help hold the shoulder in place. The vast majority of shoulder dislocations don't require surgery. The first time a shoulder comes out of place, once it's stabilized, we often can build up the muscles that help to hold the shoulder in place, and then it will remain stable after that. If it continues to dislocate, that's when we start talking about surgery to fix it. The younger you are when you dislocate the shoulder, the more likely you are to have it come out of place. So patients that are under the age of 20 the first time they dislocate, there's somewhere between a 60 and 80% chance that they're going to continue to dislocate and have problems with the shoulder and possibly need surgery. For patients that are over the age of 40, it's actually very rare for them to dislocate again, but we do worry that their shoulder can get stiff or they can tear their rotator cuff as part of the dislocation. Tommy John surgery is a procedure where we repair the ligaments on the inside of the elbow. In patients that use their elbow for overhead activity or throwing, especially baseball pitchers, they can either tear or stretch out the ligaments on the inside of the elbow, and that means when they go to throw, their elbow opens up and they're not able to do it because of pain. So the procedure involves actually using a piece of tendon, either from a different spot in the patient's body or from a cadaver, to go ahead and reconstruct that ligament and tighten up the inside of the elbow. It was first done by a doctor named Frank Jobe out in California, and the patient he originally operated on was named Tommy John, so that's where the name of the surgery comes from. The vast majority of people that get tennis elbow don't play tennis and have never held a tennis racket. What tennis elbow is inflammation of all of the muscles that extend your wrist and your fingers as they attach out here on the outside of the elbow. And so anytime you do any sort of gripping activities, you've actually got to fire those muscles stronger than the muscles that do the grip, because otherwise your hand would go down like this. And so most people who get tennis elbow get it from overuse of their hand just with everyday gripping activities. The good news is most of the time we can make that better with a combination of physical therapy and sometimes a brace. In order for any shoulder surgery to be successful, it's really important that the patient have the right physical therapy. So the first thing is the surgery, but the second step in getting better is having the right physical therapist and the right program. And one of the nice things about surgery here at Georgetown is that we have physical therapists here, but we also work very closely with the National Rehabilitation physical therapists that are spaced throughout the area, and so patients are often able to have their surgery here and then do a very well-structured physical therapy program closer to where they live. So while I may see the patient on the day of surgery, and then every 4 to 6 weeks after that, they're going to see their physical therapist 2 to 3 times a week, often for 6 months. So after the patient's surgery, we give them a prescription for physical therapy, and they're able to take that prescription to any physical therapist they'd like to work with. We have some very, very good physical therapists here at MedStar Georgetown. We also work very closely with some of the therapists in the area, especially the National Rehabilitation Hospital therapist at their outpatient clinics, which are placed throughout the Baltimore-Washington region. This can let patients work with a therapist who knows our protocols and who we're very familiar with, but is much closer to their house than coming back to see us down here at MedStar Georgetown 2 or 3 times a week, and then they can see us here just for their follow-up appointments, or even see us at the NRH centers in McLean or Chevy Chase.